The Senior Rehab Podcast is sponsored by Great Seminars and Books. If you need high-quality geriatric con ed that's worth your time and money, check out Great. Owned by the living legend Carol Lewis, Great offers courses and products created by recognized leaders in geriatrics. Learn the most effective techniques for diagnosing and treating your patients. Just go to seniorrehabproject.com/great and get $25 off by using the code SRP25. The show is also sponsored by you, the listener. Go to seniorrehabproject.com/join to find out how you can help steer the direction of this movement and join our monthly meetup. Once again, that is seniorrehabproject.com/join. Hit me.
Welcome to the Senior Rehab Podcast.
The podcast for rehab clinicians that want to better serve older adults. Shorts. This is Senior Rehab Shorts, the evidence-based segment for geriatric rehab clinicians, bringing you relevant and applicable content to better serve your patients, regardless of your setting. And now your host, Joe Daniels.
Hello, friends, and welcome to another episode of Shorts. Really excited to talk to you guys this week about a brand new paper out of the Journal of Geriatric Physical Therapy, 2017 issue, volume 40, issue 1, and it is titled Determining Risk of Falls in Community-Dwelling Older Adults, a Systematic Review and Meta-Analysis Using Posttest Probability. That's a mouthful. And so this paper has been in the work for the last 4 years, since 2013, with data collection spanning from 1990 to 2013. So that's 23 years of data and evidence packed into one little paper here, and one little table that is going to be the key takeaway from this whole thing. And so essentially what they did was took a pretest probability of 30%, which is basically the risk of falls for an older adult per year, and came up with a set of 5 medical history questions, 2 self-report measures, and then 3 outcome measures that would best identify risk of falls, cumulatively speaking, right? So right now we don't have any one tool that can, best identify a fall risk, because fall risk is so multi-factorial. And so with that in mind, as many as 1/3 of older adults fall at least once over the course of a year, and that's your 30% pretest probability. And so susceptibility to falls results from an interaction of multiple factors, right? If we think about efficacy, reduced efficacy of postural responses, diminished sensation, impaired musculoskeletal and neuromuscular function, decreased cardiopulmonary systems, deconditioning associated with inactivity, and then depression and low balance, self-efficacy, and even polypharmacy, right? And so a host of environmental factors all contribute to this fall risk assessment. And so obviously, because of the multifactorial nature of fall risk, this gets really complicated in terms of identifying who's most at risk, right? And so consequently, fall risk assessment tools are as plentiful as contributing factors in this case. And so given the number of tests and measures available for fall risk assessment, how do we as clinicians select the best diagnostic tools to examine our patient's risk of falling? And how does a given test or measure change the degree of clinical certainty that a future fall is likely? Post-test probability is the answer. And so calculation of post-test probability allows a clinician to determine how much risk has shifted from the pre-test probability of 30% over to the post-test probability based on answers to medical history questions, to self-report questionnaires, and then on fall risk cutoff scores of outcome measures. And so the first step in determining a measure's post-test probability begins with consideration of its diagnostic accuracy as indicated by sensitivity and specificity values. Now, I won't bore you all with the numbers and the data that goes into this. If you're into research, that's fine. Take a look at the paper. But basically, there's a formula that they use to come up with this post-test probability number based on how questions were answered. Okay. And so for the clinician, This information enhances determination of who and who would not benefit from a more in-depth exam and intervention to reduce risk of falling. And so I'll make a comparison here that they did in the paper. In clinical medicine, when no single diagnostic test has a post-test probability large enough to cross a threshold for intervention, the results of several tests are combined to calculate a cumulative post-test probability value, right? Think about orthopedics. You combine clusters of information to make a diagnosis more likely, right? And so in effect, the post-test probability of one test becomes the pre-test probability for the next test. And so I'll explain a little bit about that in a bit, but if both the pre-test probability is in the falls risk of 30% and a test that measures likelihood ratio values are considered moderate, as in anything over 30%, the cumulative post-test probability can be thought of as an increasing surety. And so two or more positive tests with a high cumulative post-test value, again, over anything over 30%, suggests that the individual is at a high risk of experiencing falls and supports the need for further examination and potential intervention. And so physical therapists, like other healthcare professionals, collect information about an individual's health and functional status in several ways, right? So we do this by asking questions about medical history. Do you remember falling in the last 6 months? Or by administering self-report measures. Are you fearful of falling or using a depression scale? And then lastly, by using performance-based measures like the Berg and the Tug to come up with cutoff scores. And so combining multiple sources of information assists the diagnostic process to identify issues that can be addressed by intervention. And so in terms of how this study was actually performed, I'll give you guys a little breakdown on what the actual numbers look like, but I won't spend too long there. So in terms of inclusion criteria, studies had to have a fall status. So did they fall or did they not? Have a minimum sample of at least 30 community dwelling ambulatory older adults, either with or without an assistive device. And when I say older adult, I mean older than 65, and had to track falls for at least 6 months. In terms of exclusion criteria, could not be in an acute care setting, could not be in a long-term care setting, could not have any significant cognitive decline or neuromuscular disorders. And if the study utilized less common equipment like force plates and things of that nature that weren't available in most settings, it was also excluded. And so in terms of databases, Medline, PubMed, CINAHL, from January of 1990, when commonly used measures first started to develop, all the way up until September of 2013, so 23 years worth of data, when data examination began in 2013. And so the quality assessment tool for diagnostic accuracy studies, or short QUADIS, was used to evaluate each study's methodological quality. And so they started with 2,294 total abstracts. That was narrowed down to 364 after an abstract review by the authors, and then further rescreened to 184 before quality assessment. And so before quality assessment, or after assessment rather, 95 were left for data extraction using QUADIS. And so 95 studies obviously fully met the inclusion criteria. Of those 95, 59 contained the information necessary in terms of specificity and sensitivity to calculate the post-test probability. Now, in terms of strength of evidence and levels of evidence, in terms of the QUADIS scores, level 1 evidence was considered a prospective study with a QUADIS score of more than 75. Level 2 evidence was a prospective study with a QUADIS score of less than 75. And then level 3 evidence was a retrospective study regardless of the QUADIS score. And so of the 59 studies included in the systematic review, 27 of them were level 1, 5 of them were level 2, and 27 of them were level 3 evidence. And so initially, 112 test and measures were included, and then sensitivity and specificity value was only available for 56 of the 112. And then evidence tables, including the post-test values, were constructed for 15 medical history questions, 15 self-reports, and 26 performance-based measures from 1990 to 2013. So of those 15 medical history questions, 5 of them had the best evidence and the largest increases from the pretest of 30%. And so here are the 5 questions, right? And so have you fallen previously? Any reported previous falls? If the answer is yes to that question, their risk or their post-test probability of falling increases to 44%. The next 3 questions all had the same increase from 30 to 38%. And those were any use of psychoactive medications. So basically depression, anxiety, things of that nature, and it's requiring any assistance for ADL. So do you require any assistance in your ADLs? And are you fearful of falling? Those 3 all had an increase to 38%. And the last one, do you use an ambulatory or assistive device? Increased to 36% probability if answered yes. On the other end of that spectrum, 4 out of 5 of these questions, when answered negatively, reduced the post-test probability to 26%. And so that's something we'll look at later as well. So of the 15 self-report measures, 2 of them had the best evidence. The first being the Geriatric Depression Scale, or the GDS-15, with a cutoff score of less than 6. And then the Falls Efficacy Scale International, with a cutoff score of 24 or more, increasing post-test probability value to 42%. And so that's the medical history questions and the self-reports. Now, in terms of performance-based measures, of the 26 of them, 7 had the strongest evidence and 5 were put into use in the cumulative bang for your buck at the end of the paper. So in terms of performance-based measures, obviously they have a stronger ability to predict falls than history questions or the self-report measures. And so I'll run through some numbers real quick with you guys just because it needs to be put out there in terms of sample size and how much data is truly in the studies for you guys to have an idea of why they chose these tests. So we'll start with the ones that you all are most familiar with, those being the Berg, the tug, and the 5-time sit to stand. And so those are the 3 that are combined at the end. So with the Berg, score of less than 50, increased risk of falls or post-test probability to 59%. A score of 51 or more on the Berg, decreased risk to 23%. Combined sample size of 1,130. The timed up and go, cutoff score 12 seconds or more, increased risk to 47%. Less than 12 seconds, decreased risk to 25%. Sample size 6,410. 5-time sit to stand, 12 seconds or more, 41% risk of falls increased from 30%. Less than 12 seconds on the 5-time sit to stand, decreased risk to 20%. Sample size 3,319. In terms of screening tools, again, which I'll talk about at the end here, single limb stance, eyes open, less than 6.5 seconds, increased risk to 45%. More than 6.5 seconds on the single limb stance, decreased risk to 28%. Sample size 3,015. Second in the screen is the self-selected walk speed, less than 1 meter per second self-selected walk speed, and I believe this was done in 10 feet or so, maybe 10 meters. Less than 1 meter per second, increased risk to 39%. More than 1 second, decreased risk to 20%. 1,354. Also worth mentioning, a speed of 0.6 meters per second or less, increased risk to 61%. 0.6 meters per second or more, decreased risk to 23%. They also looked at the Tenetti and the DGI. The DGI isn't really worth mentioning because of the small sample size. And the Tenetti also had a decent sample size, 1,374. So the Tenetti score of less than 25, increased risk to 42%. A score of more than 25, decreased risk to 23%. And so those are the big ones in terms of performance-based measures there. So in terms of weaknesses or limitations of this article, obviously limited to articles from 1990 to 2013. And so likely additional evidence has been published since September of 2013. And I know there has because I've read a lot of it. Obviously, there was a lack of information of ordering search terms through a medical librarian early on during data extraction, which threatens the replication of the study. Third, the inclusion of retrospective studies may have elevated the ability to predict falls slightly, but were included because of the limited number of prospective studies available in the literature. And then lastly, the variation in study quality between level 1, 2, and 3. The methods in the analysis also present a significant challenge to the synthesis process of this data. And so, in beginning the wrap up here in summary, so although no single medical history question emerged as a powerful diagnostic tool for identifying older adults at risk of future falls, queries about fall history, ADL difficulty, use of ambulatory device, concern about falling, and use of psychoactive medication in combination are likely useful for initial screening. And so yes responses to any of those questions can be used to identify those who would most benefit from a comprehensive risk assessment for falls. And then right underneath that paragraph, guys, is Table 5, and it's titled Summary of Clinically Useful Indicators of Risk of One or More Future Falls Based on Pretest Probability of 30%. And so that's going to be the one that you're going to want to cut out and laminate and have with you at all times, especially when you're doing your evaluations, to have the numbers right there. So, and then if these questions are conceptually independent of each other, it may be appropriate to use one question's post-test probability as the next question's pre-test probability to develop a cumulative estimate of post-test probability. And so clinicians can quickly calculate cumulative post-test probability with online resources, which I will put in the show notes for you guys. And it's basically a calculator. And all you do is you use the pre-test probability for one, and then you use the post-test probability for the next question, and you would put the likelihood ratio in of the question you're using. And so I'll go over that a little bit more later, or you all can contact me if you need further information about how to add that stuff up. But I want to provide you all with an example of how powerful this cumulative post-test probability can be in terms of cumulative fall risk and what that looks like on a picture with a patient. And so as an example, during an interview, an older woman reports a previous fall, sleeping pill use, needing assistance with bathing, being fearful of falling, and use of a cane for ambulation. So positive on all 5 of those questions. So assuming the pretest probability of 30%, her cumulative post-test probability will be calculated using the largest post-test probability as the next measure is pretest, and then multiplying by the test positive likelihood ratio, which you would essentially do in the calculator. But you plug it all in, it does it all for you. So in this case, if you started at 30, it would increase to 44 based on the basis of fall history, increase to 52 based on sleeping pill use, increase to 60% based on self-reported fear of falling, and then finally to 68% due to use of a cane to walk. So this demonstrates a 2.4-fold increase from the original 30%, and would support the need for a more in-depth evaluation of balance and risk of falling. And so conversely, if we look at that on the other end of the spectrum, a post-test probability for an individual with no previous falls would drop to 26%. No use of psychoactive meds would drop to 22%. No ADL difficulty further drop to 18%. No fear of falls, 17%. And then no need for an assistive device would drop to 16%. So they're reduced by half from the pretest probability of 30%. And so education about home safety and value of activity may be sufficient enough to address this person's fall risk versus the other patient who we mentioned about who had 5 positive history questions. And so, again, in summary here, physical therapists and others using these tests will need to determine the post-test probability threshold needed to trigger intervention on the basis of their clinical judgment. And so a post-test probability of 60% to 66%, for example, would suggest an individual is having a 2 in 3 chance of future falls. And I would argue really anything over the 30% baseline would warrant a further examination and potential intervention depending on what the findings were. And so this cumulative evidence-based quantitative approach to multifactorial fall risk assessment would be valuable, obviously, and require documentation to explain and support recommendations for further evaluation and intervention. So this approach also provides a tool for a patient and family education and for communication among the team to explain the level of risk and the need for intervention. And then finally, as the level of risk decreases after intervention, you can use the same approach again to go back and reevaluate the outcomes of your intervention. And so, what I'm trying to do a better job with in these shorts, guys, is there's a lot of data and I'm trying to, keep it relevant. But I want to add this little tidbit at the end with the key takeaway. And so here it is. Combining these 5 simple medical history questions with 2 quickly implemented performance-based measures. And so that would be a single limb stance of less than 6.5 seconds and a self-selected walk speed of less than a meter per second may be a useful way to identify persons most in need of a more in-depth examination of balance. So you would use the 5 medical history questions, and then you would add a single limb stance and a self-selected walk speed and use that as your screening tool. Now, previously it mentioned that if you have a positive on 2 total, so one of the, it could be one of the 5 medical history questions and then 1 outcome measure or 1 self-report, or you could have 2 medical history questions. That's going to be your need to examine further. Even 1 would be over 30%, but 2 of them at least would warrant a further screen. And so after you do your screen and you find, you get some red flags not red flags, but you get positive answers in either your medical history or you are less than the cutoff score for the single limb stance or the self-selected walk speed, you would then combine that with 3 performance-based measures. And so you would do the Berg, the timed up and go, and the 5 times sit to stand. Again, the Berg cutoff score, less than 50, timed up and go time of more than 11 seconds, and then a 5 times sit to stand test of more than 12 seconds. And so these provide not only the opportunity to identify positive or possible modifiable risk factors to inform intervention, but also the means to quantify change in risk after intervention. And so those tests and measures gives you another way to look at the way that someone's moving, their strength, their range of motion, and their balance. And then additionally, 2 self-report measures, the Geriatric Depression Scale with a cutoff score of less than 6 points and the Falls Efficacy Scale of more than 24 points would provide additional insight into contributors to risk of falling and as part of an in-depth exam and evaluation. And so cumulatively speaking, guys, what you want to do is get your screen. So answer those 5 questions, single limb stance, self-selected walk speed. If they do poorly on any of that, then you would go into your Berg, your tug, and your 5 times sit to stand. And that's it. And so you would plug whatever values you have into that calculator and come up with a cumulative fall risk. And so if they answer negatively on those questions, my assumption would be that you would take away first from the 30, you would go down, and then from the positive questions and from the lower outcome measure scores below the cutoff, you would go back up and you would see if they're above that 30% fall risk. And so that's essentially it in a package, guys. Again, if you have any questions, definitely feel free to reach out to me. My contact info is, as always, in the show notes. If you have a hard time finding this article or need a hand, explaining any of the tables or what any of these numbers mean, definitely feel free to reach out. Continue to provide feedback on the Facebook page. Trying to make these the best and most efficient episodes for you guys, so you can really, if you need to, just skim to the end and see what the takeaway is. And then what we're trying to do is, what we've mentioned in previous meetings, is to come up with a simple graphic based on all these evidence-based podcasts for you all to have, like some things that have been floating around on social media, so you have something concrete just to look at, like the table in this paper. So Any questions, feel free to shoot towards me, email, Facebook, whatever is comfortable for you guys. And until next time, stay funky, my friends.
Hit me. Thank you for listening to the Senior Rehab Podcast. I appreciate your time. And if you enjoyed this episode, do me one favor. Share it with one other person that would benefit. Thank you. If you want to see the show notes or find more episodes, just go to seniorrehabproject.com. And until next time, my friends, do not forget to stay funky. The Senior Rehab Podcast is sponsored by Great Seminars and Books. If you need high-quality geriatric con ed that's worth your time and money, check out Great. Owned by the living legend Carol Lewis, Great offers courses and products created by recognized leaders in geriatrics. Learn the most effective techniques for diagnosing and treating your patients. Just go to seniorrehabproject.com/great and get $25 off by using the code SRP25. The show is also sponsored by you, the listener. Go to seniorrehabproject.com/join to find out how you can help steer the direction of this movement and join our monthly meetup. Once again, that is seniorrehabproject.com/join.